So now we have a chance to do some questions and answers. And if you would stand up, state your name and your affiliation, and let's go ahead. Questions?
Hi, my name is Annie. I'm a recent alum of the Executive MD program. I'm currently an analyst at a community hospital here in California. And my question is, I think we can all agree on where the field is going. We can all, agree with value-based care. However, as a nonprofit freestanding hospital, and as an analyst, I see kind of the resources and the lack thereof to really build infrastructure, data analysis, and I'm thinking, seeing all the consolidation with health systems and insurance agency, I'm concerned about smaller physician groups, freestanding hospital, and how that they will be affected. Is CMS providing adequate resources for smaller organizations to really keep up with this push towards an integrated health system?
It's a great question.
Yeah. Thanks.
It's a great question. I think since you mentioned CMS, maybe I can briefly address it, and then certainly I'm sure other folks will have things to say. But in my outreach across the region, you've highlighted the exact group of people that I am working very hard to connect with. Solo and small practice clinicians who may be not necessarily geographically isolated, but they're in communities that traditionally have not collaborated like some of our larger systems. And that's true in urban Bay Area as it is in rural Hawaii, for example. You mentioned in particular, what are we doing to help support clinicians who may not even have an EMR, aren't doing this kind of workflow. And one of the newest bundled payment programs that is starting actually this Friday, April 1st, which was mentioned earlier, is what we're calling CJR, or the Comprehensive Joint Replacement Bundle, which really, it's mandatory for certain areas in Region 9, and in particular the Los Angeles area. And so I'm sure this is something you're dealing with. There are specific technical support teams for each hospital that is on the hook for providing care that is going to be measured very aggressively in terms of its quality and resource intensivity. But many community hospitals are struggling to make those connections with their skilled nursing facilities, rehab, and other just community docs who are orthopedists who are going to be participating in this bundle but may not realize how important their involvement is. And that is something that we're trying to really aggressively work with the hospitals on. I'm also happy to make myself available to make that clinician link with sometimes physicians who don't quite understand the method behind the madness, which is where a lot of my work tends to come in. Another piece of that, in addition to sort of model-specific technical support, is the Transforming Clinical Practice Initiative that I mentioned earlier, which essentially is free technical support to physicians and clinicians of any mode of practice and in any kind of system, and to help specifically with putting together processes to truly achieve continuous quality improvement in order to be successful under a model like CJR. So I'd be more than happy to follow up with you too. Yeah.
Thank you.
Additional responses? Or?
Yeah, please.
And I'm sorry, just one other comment. I think your question is spot on, and I think across the country it's going to require investment, infrastructure, competencies, and capabilities. I think it is really hard to deliver very high quality care, clinically efficient care, and offer the best possible patient experience. And I think that will drive affiliations, partnerships, collaborations like we haven't seen in the past. And the results I shared before, I think it's really a first step. It's a very long journey. It's a first step. It's a small step. A long way to go for all of us, including certainly those of us at Cedars-Sinai, before I don't think we ever achieve an endpoint, but as we go farther along. So I think we're going to see many more partnerships, affiliations than we saw in the past.
And I'll just add, I agree with your point. One of the flaws I've seen in the early versions of these models, particularly with the MSSP ACOs, is that it's like a public budgeting type model where the money you save goes away the next year, and you start with a lower budget the following year. And so what we have is we have a disconnect right now in this early form of value-based payment in Medicare where you're almost penalized for being efficient. And we saw that with pioneer ACOs in particular. We started out with 6 here in California, very enthusiastic, and we lost, I believe, half of them, particularly healthcare partners, because it was so efficient, they scored poorly. And it's tough. So, some of these models are great for beginners, and some are not so great for more advanced. And one of the things I've noticed in the current evolution of the rules that are coming out is that there is a growing recognition at CMS that you have to have a couple of different tracks. And so it will evolve over time. It's going to be painful, but I think we have been heard, and I think some change is on the way.
Question? Over here.
I'm a health lawyer. I teach health law here at UCLA. Great panel.
Thank you, Tony.
I would just say preparatory, this is directed to you, Dr. Wolfe, that nobody has a bigger, tougher job than CMS, and your generation of physicians and your leadership of your colleagues is recognized. I will use the example, however, of change management, and my question does go to the CJR program specifically. As it happens, one of my great joys is building Center of Excellence programs, and I built some big ortho programs, and I'll tell you that it's a very interesting dynamic that's going on. You also know what April 1st is in other realms of societies.
Okay.
The issue that I would raise is that as the change management is that it's a Herculean job to look at bundles, and I know you know the difference between a bundle and an episode of care, but the lack of data sets and the lack of EHR that talks. I mean, I have a program that is on Epic. I'm looking over at my colleagues from Cedars, my father's hospital, and I will tell you that Thank you very much. But what is very interesting is that the EHR systems aren't talking to each other. And in one case, where we have a program where one of my groups uses, several of my groups use VecGen, they've actually had to demand the folks from both companies come out and talk. Those systems aren't talking. There aren't common data sets. There aren't agreements in place with any of the vendors. Most of the medical community is totally confused by MIPS, by MACRA, by whatever the acronym of the week is. And again, it's absolutely not your fault, but some of us cheered when we saw last week the report that a bill was introduced in Congress to delay this. I mean, I'm not sure, and I realize you didn't set the policy. Can you explain, other than the fact that we know there's a looming shortage of money, can you explain why this is being crammed down? Because very few places outside of a major world-class center like the Cedars or this university, Celsius, we're not ready for this. How are we going to manage this if the doctors at the end of the day wind up saying, you know what, it's too much, I'm going to quit? And I'm telling you, as somebody that wants to rely on the health system, I hear nothing but from people, 2019, I'm probably out of here.
Thank you for those comments, and I think you're not the only one I've heard those from. And I think one of the real challenges our agency has is that our board of directors ultimately is Congress, which tends to set our priorities and change them depending on sort of their view of the world as they see it. With respect to the Comprehensive Joint Replacement Bundle program, will go into place on April 1st. It's not an April Fool's situation. But I think you highlight some of the biggest challenges that we're facing right now, not just related to this model, but in general related to data reporting and just doing the right thing for the patient, which is, and I use NextGen in my clinic too, and there's issues with every EMR. But the fact that EMRs don't talk to one another is a huge problem that actually Congress has recognized, and in MACRA has given our agency the authority to develop interoperability standards such that we can redirect this market that is developed whereby the cost is being passed on to clinicians to pay for patches in order to allow even hospitals that are using the same system to actually talk with one another and share data. So that's one possible opportunity moving forward, but it's certainly not going to be in place by Friday. There are successful entities out there in Region 9 that have been working with vendors to develop their own version of interoperability. And we're actually doing a lot of listening and feedback sessions with those folks to gain a better understanding of how to direct vendors and the EHR companies themselves into working more closely together. At a conference just several weeks ago, our acting administrator, Andy Slavitt, made mention of the fact that we have gotten the agreements from a large number of the major players in the EMR world to pledge to work towards developing interoperability standards. So that's one aspect of your question. As to why the bundle is mandatory and being put in this aggressively, unfortunately, I don't have a great answer for you. This was something that actually came out of the Office of the Secretary of Health and Human Services, so it wasn't even developed by CMS.
It's not the bundle, it's the episode of care where there's liability if somebody has an MI, 30 days later, or pulmonary embolism. They have nothing to do with the care that was given at the facility. The medical community is not generally prepared to manage those kinds of risks, and most hospitals aren't. And so it winds up being a system of frustration. I mean, most of us in healthcare really want to advance. We really want healthcare to be better, and we want it to be cheaper, and we want it to be more accessible. But damn, this is just
But you need to spend the money.
Frustration.
You need to spend the money on IT infrastructure, and you haven't to date. And I think that you have to catch up.
My folks have. They spend millions. They spend millions, and they're in a situation where the systems aren't communicating.
Well, and I think your concerns are well heard, and CMS is listening to these issues aggressively. And I want to make sure that we have time for other questions, but just to close, I think I'm actively taking notes as we're talking about all these things, and one of my big parts of my job is to take this feedback back. But I will also say that we all do want to do the right thing as clinicians, but none of us as patients, or if one of our relatives was in a situation where they had a PE or an MI post-op, that's not the best outcome for that person. And the question is, how do we put the systems in place in order to really reduce those possibilities aggressively? And the CJR bundle model is one way of trying to start doing that work.
Okay. I have a different answer to your question. This is the end of an 8-year administration. And if these rules aren't issued, from the administration's point of view in DC, if these rules aren't issued now, in the final year of the administration, they may never be issued. And so that's the mindset. And so you're going to see a lot of paper coming westward from Washington, DC this year, and that's just the way it's going to be. So that's the cheery news of the night.
Thanks. More questions back here? Hey, Frank. By the way, Frank and I are classmates from the 1972 MPH.
Right.
We go way back.
Wow.
I was going to say, I'm affiliated with the Torrens School of Instructional Learning. Thank you, Dr. Torrens, for considering me and your degree from this great university. So here's what I'm interested in, and you guys are uniquely qualified to respond. There are other affiliations going on in the healthcare world, and that has to do with neighborhood health centers, community health centers. There's all kinds of talks on the west side, downtown, San Bernardino, neighborhood neighborhood health, I'm talking federally funded 330 affiliated, hospital affiliated with medical groups bill. And I'd ask for your comments on that kind of an operation and development. How do you see it playing out?
I'll start. Okay. Since I spend a lot of time in Sacramento, what I see typically on, most days of the week is healthcare is so siloed between all the different stakeholders that, people are fighting for their share of the pie and resources. And so there's tremendous amount of competition in the policy arena, between clinics and hospitals and physician groups and independent physicians and every specialty of physicians. And then there's the nurse practitioners and the PAs, and it goes on and on and on. And some of these models that are emerging, like New York's waiver program with their performing provider systems, Oregon's CCOs, coordinated care organizations, turn this whole situation on its head. Create a budget, a global budget. Get everybody in a room and say, this is it, make it work. Good luck. And it is working, slowly. Not easily, not smoothly, but they're moving forward in these models. And I'm a little disappointed to see that we're not doing more of that in California. But I think eventually we will. I'm seeing small pieces of it in the state Medicaid program here, with the Health Homes program, 2703. Under the ACA, there's a capability there for collaboration with the new whole person care program that'll be coming out shortly. I think there's baby steps going on. It's good. Tremendous efforts to integrate behavioral health care now with social services and with medical care. We've all been struggling with the duals here for 2 years now with the rollout of the duals, particularly in LA County. A long way to go. The rules have to be adjusted as we go along. So.
Yeah, and just to add to that, in addition to the programs that Bill mentioned, there's always a challenge with CMS being both the federal authority and sort of the money matcher with states who are setting the policy around Medicaid programs, and that inevitably affects the dual eligible population, which I would argue is probably one of the most vulnerable groups that we care for. And to date, there is only one model that's out there that really addresses social needs and the social determinants which often affect a dual eligible's ability to stay out of a hospital, for example, or to really experience the true quality of life that comes with the management of multiple chronic conditions. And that model is the accountable health communities model, which looks very similar to California's whole person care model, both of those models being open for application right now. A lot of community health centers and other community-based organizations that aren't necessarily medical are working together to try to put an application forward for one or both of those programs. So that's really exciting stuff and not an opportunity we've had ever before. So lots more to come to see how those applicants are successful and then what they do with the opportunity.
Bill mentioned it's slow, and it has started out slow, but in California we started working with a couple of health centers about 2 years ago, so I think it's going to speed up and we'll start here and spread, hopefully with the rest of the team.
More questions? Here we go. Rick?
Hi, I spent much of my career in academic medical centers, and is CMS in any way working with the AAMC? Given your timeline, this is a 10-year timeline, what is being done to educate the physicians of tomorrow as they go through their educational process in this dramatic change in the healthcare industry and the delivery system?
It's a great question, and we don't necessarily have a 10-year timeline, but we have a timeline that will probably be perpetual, simply given the amount of work that needs to be done and the way that our health system does need to transform in order to truly manage our population at the level that they deserve. It's a great question because it's one of my most favorite topics. In another life, I actually sat on the Son Brown Commission. for the state of California. And so workforce is a key element of a lot of my past life that I've been involved with, but I also see workforce as a huge issue when it comes to the integrity of the Medicare and the Medicaid programs. And I think CMS would agree that workforce is a primary issue that we haven't really been involved in. But under the health equity plan, that is one of our priorities, to look at the workforce capacity and our ability to provide care for all these people who have new insurance. And that brings me back to your question, which is how do we educate folks who are quote unquote in the pipeline? Part of my work is actually going out to lecture at various training programs, which are beyond just medical schools. I'm doing work with nurse training programs, PA training programs, public health, obviously, and of course the physicians. And every regional medical officer does have that as part of their work. We are also collaborating with organizations like the AAMC and all of the specialty societies, as well as public health entities and patient advocacy groups, in order to really hear and listen carefully as to what the issues are in training the pipeline, so we can provide the appropriate information at the right time. I think one of the biggest challenges is that a lot of us don't learn about these programs until we're out in practice and learning how to code 99214 and realizing how important it is to get the right codes to get credit for the work that we're doing. And so a lot of emphasis is being placed on providing that information up front. So we've got a lot of work to do, but it is an active issue that we're aggressively discussing.
I've had the opportunity to speak to a number of residents and had the opportunity also to speak to a number of the UCLA medical students, and I'm very encouraged about the future, the so-called manpower pipeline as it's been described, that when you have discussions about the future of healthcare, new models for the delivery of healthcare, whether it's team-based care, physicians are part of a team, using big data to identify high-risk patients, virtual care, virtual services, digital health, using new technologies to improve quality, value, patient experience. We talked about all of the things, e-visits, or patients can get care when appropriate in their homes. A lot of the medical students and the residents really light up, and they're excited about entering a healthcare system with these new technologies, new approaches to care, again, team-based care. And academic medical centers, I believe, they have a number of challenges, and related to the mission, in addition to patient care, research, and teaching. But I believe they have some advantages as well. And academic medical centers, in general, are very good at innovation, and they discover new molecules and devices, and a lot of very talented people. And if you take that mindset towards innovation and you use it to create and test and implement and improve new models of delivering care. So innovation, not about molecules, but care delivery. I think academic medical centers have great promise for helping lead the way, and it's a tremendous asset for academic medical centers.
Question over here.
And I'm a senior project manager currently, and I finished the first phase of 4 health information exchange with a large team, of course. And it's a significant step forward for interoperability, and our providers, especially on the practice side, really love it. You can see them changing their workflow to have access to the inpatient data as they see their patients and also.
Okay.
So I'm really invested in that segment of the market, and I work both for a vendor and for the provider, so it's kind of a unique slice of life. My question is around interoperability, and it's formulated as I go use it very quickly. I have a big heart for the public health agencies and the small practice physicians. We're looking to expand into smaller practices that are part of our IPA. And we're going to be doing the grunt work, training them, helping them talk to their vendors so that they can get the tools they need to even integrate with us. And all of this is being driven by, what is the motive? The motive is capitation. So the large corporately funded provider so they can benefit from the data. And that's really what I see as the driving force here. And yet my heart goes out to the public health organizations. What is going to help them plug into a global interoperable data system someday? I've heard that Great Britain, although socialized medicine and has a huge advantage of smaller, implemented their HIV nationwide in 2 years. Perhaps an underestimate. But when I look at our market-driven situation and all the slices of pie that are getting nibbled away, it's really frustrating. And I can't see how people in need are going to benefit from what we know interoperability can do. So I just wonder, what are your thoughts on, will there be any federally funded or incentives to help us get beyond the motive that I see, and that's corporate interests driven by their contracts going towards value and spending money to save the dollars, and yet it's another example of the haves and have-nots. Who's going to fund the public need? Whereas the need for equity in healthcare is greatest to begin with. So I just throw that out there and see what your thoughts are.
Thank you for the question. We'll let
Sure.
the panel.
Yeah, I think it's a great question, and you bring up multiple points which are really essential we need to voice those in order to drive the conversation more extensively. The simple answer is right now there's no federal lever to do that. Even within MACRA that allows CMS to develop interoperability standards, there's no lever that we have or authority that Congress has given us to implement a nationwide HIE, for example. However, several states are doing really interesting things with their HIEs. Nevada is a great example where they've actually linked their public health departments as well as a number of behavioral health entities into their HIE, and that's simply been something the state has chosen to do. And so every state is doing something slightly differently or not at all. And so it's a little bit fragmented, it's piecemeal, and traditionally that's been the way a lot of these things have developed over time. Will there be an opportunity in the future? Possibly. It will probably depend on how Congress sees it and what they think of our development of interoperability standards as a first step.
I was just back at a meeting discussing this, and you really need two things. You need standards, and you need really the making interoperability a priority among all of the EHR vendors and technology vendors. The standards are getting a lot better. There's some really smart people working on standards, and the standards have improved significantly. So I think we're getting close, very, very close to where we can do it. New standards for smart on fire and all kinds of new standards have emerged that hold terrific, great promise. And I think part of it, the discussion at the meeting, was about having the EHR vendors put it on their product roadmap, prioritizing it, these new standards. And at least the discussion at the meeting, I think one of two things will enable that to occur. One is possibly regulation or federal direction. The other is which a lot of the EHR vendors convene their clients and they bring them together, and the clients provide direction on what the priorities should be. And for clients of the EHR vendors to say, wait a second, before we talk about other features and functions, let's really figure out interoperability and try to put adoption of existing standards near term on our product roadmap. So a lot of discussion. I'm optimistic that we'll get there in terms of interoperability, but nothing in the immediate future.
I'm a little less optimistic.
Okay.
So there's a history to this. In 2008, when the High-Tech Act came out and the subsidy, I was in D.C., I was at our lobbyist office, and we got a call from staffers at the Energy and Commerce Commission, and they were writing the High-Tech Act to provide the stimulus for EMR adoption. We pushed hard in that phone call to get them to recognize IPAs and multi-specialty medical groups as the low-hanging fruit to expand EHR adoption. especially in a state like California, because most of the groups have some level of EMR adoption, mostly among primary care doctors, less so among specialists, particularly when the specialists are non-exclusive to the group. I mean, that's the reality. But you have these little hubs of EMR connectivity, and it's, you know PAH. I mean, you've got one system, you maintain it for your doctors, you train them when they change, you keep the system running. The stimulus came to California. First we had CalRio, then we had CalEconnect, and then we had all the, whatever the acronyms were, they've all gone away. It resulted in this fragmented approach where small and solo practice doctors went and chose from among 100 different systems. And everybody bought their own system. And they'll probably all just die on the vine because organizations aren't maintaining it for them. And this is a tragedy because, in particular, we knew that there was going to be a run-up to the Medicaid expansion in California. And those doctors in particular don't have the funding and the capital to build EMR systems or to be part of a network that has EMR support for them. We missed the boat, and now we're going to pay the price because we have all of these standards coming down the pipeline, particularly in Medi-Cal, for performance measurement, and the doctors in those Medi-Cal networks that now serve 7 million people among capitated delegated groups don't have the connectivity, don't have the systems in place. I don't know how we're going to catch up. You have to start by recognizing that the policy does not meet reality if you're going to fix the problem. Okay.
Yeah, that really had to be our last question. We have a time constraint. So
it's good to end on a high note.
So I want to thank the panelists, if you would please. I also want to thank Paul Torrens for everything.